Thank you for
Doing
your
great, thanks. How are you?
I am so well. Thank you for asking, Dr. Burkhart. I am very, very interested in tonight's conversation because there's so little talked about when it comes to pancreatic cancer. And so I'm so excited to hear your insights and what you have to offer for us this evening. So before we get started, could you tell us a little bit about yourself and then one fun fact that you would like to share with us?
Sure. So first, if my Wi-Fi is a little spotty, I want you to let me know. I've got a Wi-Fi extender I can swap around, but we'll try this
Okay.
out for now. So my name is Rick Burkhart. I am an associate professor of surgery and oncology. I work at Johns Hopkins, and I'm a pancreatic surgeon. So I'm primarily a pancreatic cancer surgeon. I do operate in patients who have other types of cancer, liver cancer and gallbladder cancer, but most of my work is done in pancreas cancer, and my research lab focuses on pancreas cancer. I've been at Johns Hopkins since 2015. I previously trained in Philadelphia and Boston, and my fun fact would be that I've never lived more than 10 miles from I-95, but I've lived from Miami to Boston.
Oh, wow. Well, that is right up all up and down the 95. Well, I'm glad
Sure.
that you stayed close and thank you for participating with us today and all the work that you have done so far. And we look forward to hearing about hope that you have when it comes to pancreatic care and research. So
Absolutely.
getting started, for those who are unaware, could you explain to us what pancreatic cancer is?
Sure. So the pancreas is an organ that lives in our abdomen, so in our bellies, and it's really far back in the belly. It sits between the major blood vessels of the body and the spine, and then in front of the pancreas is the stomach and colon and all the bowels. So it's an organ that's really tucked away back there in the abdomen. And the pancreas has really two main functions. The two functions of the pancreas are first to produce hormones, and the most common one that most folks have heard of is insulin. So,
Mhm.
for example, the pancreas helps to control our blood glucose levels. And sometimes when folks have problems with the pancreas, they can develop diabetes. The second function of the pancreas is to produce digestive enzymes to help you process food, break that down appropriately, and then gain all the benefits of eating and drinking and growing and all those sorts of things that we do. Just like every other organ in the body, the pancreas over the course of someone's lifetime undergoes changes. And some of those changes are great, and some of those changes are not so great. Part of the aging process is that cells can change, and the genes or genetic code that is made of DNA for all of our cells can mutate.
Mm.
And when that happens in the pancreas, you can become at risk for a disease, pancreas cancer. Pancreas cancer is a tough disease to treat, but it arises from these cells of the pancreas that mutate and change over time and then invade the body and can spread other places throughout the body to kind of take over and shut down other things in the body. So that's in a nutshell, that's kind of where the pancreas sits and what cancer might be.
And so when it comes to pancreatic cancer, and because it's a very tucked away, not only is it tucked away in the body, but it's also tucked away in conversation, right? So when it comes to what are some common misconceptions when it comes to the education about pancreatic cancer awareness and understanding?
Yeah, I think you're exactly right. I think as you're pointing out, pancreatic cancer, most folks don't really hear a lot about it in the news until they hear a tragic story. And those tragic stories happen with enough cadence in the news that folks tend to develop a set of beliefs around pancreas cancer that can be really damaging to their own health or can prevent patients from seeking help when they might need to. Some of those things that folks might come in that are misconceptions are that there's nothing that we can do to help monitor for pancreatic cancer or screen for pancreatic cancer. Another might be that folks could feel as though there's no treatment or no hope for pancreas cancer or no capacity to cure a patient once they've been diagnosed with pancreas cancer. Those are a couple of common misconceptions that can exist. Around what I do, which is primarily surgery, there is also a misconception that the surgeries that we do dramatically alter someone's life and leave them unable to participate in a normal life thereafter, and things of that nature, which together with my colleagues in surgery and in oncology, we try to do our best to combat those myths, of course, when we're presented with them. But it can be a challenge to get the message out to everybody.
Understood. And this is why we have forums like this, because we want references for people who are maybe misled or maybe have, some misconceptions about that. So what are the primary risk factors associated with pancreatic cancer?
Yeah. So the common risk factors, of course, the first is age. Just like many cancers in the body that take a lifetime of mutations to sometimes develop and cause that tumor, as we age, we become at more risk for cancers in general, and that includes pancreas cancer. That, of course, is not what we would call a modifiable risk factor. We can't necessarily change our age.
I wish.
Yeah, there are other things, however, that we can do that can alter our risk. So, risk factors for pancreas cancer that might be modifiable. One is smoking and tobacco use. We know that smoking and tobacco use correlates with a higher risk for pancreas cancer in our patients. A second is obesity. So, patients who maintain an above average BMI and are classified as obese actually have a higher risk of pancreas cancer. For patients who have pancreatitis or inflammation of the pancreas, whether that's driven by a behavioral cause, like sometimes alcohol can do that, or a non-behavioral cause, gallstones and things of that nature, folks who have pancreatitis are at higher risk for pancreas cancer. And then there are folks who have a genetic mutation that might be inheritable or a family risk for pancreas cancer. And in those cases, we often have the capacity to monitor patients or screen them in a way that's informed by some of the work that we do all the time at Hopkins.
So you mentioned that one of the risk factors is obesity.
Mhm.
Are the foods that we eat, or does that play a role in our risk for pancreatic cancer?
So we don't know if there are unique foods that would disproportionately increase our risk. We really haven't found data to suggest that, for example, there's a notion out there that red meat might correlate with colon cancer, for example. We haven't found that type of direct association with a particular food or nutrient and the development of pancreas cancer, as we might have found in other types of diseases.
So would the correlation with obesity be more related to the instability of blood sugars usually seen by people that are obese, or
Certainly, we do see diabetes overlap as a diagnosis with pancreas cancer quite frequently. Whether this is truly due to inflammation that arises in the pancreas from, minor pancreatitis or problems with blood glucose regulation or other things that are associated with obesity, we just don't really have all those answers yet. But we do, of course, know that obesity is a risk factor for pancreas cancer.
and does pancreatic cancer, is there a gender sway? Is one gender more affected than the other?
Doesn't seem to be outside of that, which might account for some of the behavioral things that can drive pancreas cancer, smoking, obesity, etc.
Understood. Thank you. And what are some early signs that and symptoms that somebody should look out for and maybe start talking to their doctor?
Yeah, so there's a lot of things about the pancreas that are rather vague. It's, as we talked about, an organ that lives so deep inside you that small little changes in that organ can be very difficult to appreciate clinically, or even as you're going on your day-to-day activities. You don't feel a mass, you don't feel a lump. Most folks don't necessarily experience changes to their nutrition or their diet or their bowel habits. Nevertheless, those types of things are things that should be addressed with your physician, with your primary care doctor, or otherwise. There are common things or things that can be a little more common. First of all, the development of jaundice or your skin and eyes turning yellow. That's a warning sign that one of the tubes that carries bile through the pancreas isn't functioning properly. That is an early warning sign for many of our patients with cancer in the pancreatic head. Unexplained weight loss can certainly be associated with a cancer like pancreas cancer as well. Then there are things like the development of diabetes in patients who you might not otherwise expect diabetes to develop. That can be one of those early warning signs to tell a physician as well. Those tend to be the major things that can drive a presentation to us as a group.
And so it sounds like some of those symptoms also can maybe be correlated with something else. And does that play a role in why pancreatic cancer is often referred to maybe as the silent disease, the silent cancer? Because
Yeah.
it seems that most people don't get diagnosed until really late um, in the stage.
That's exactly right. So the way we stage cancers is largely based on the capacity to cure someone with an operation in
Mhm.
combination with the potential that that cancer had gone to either lymph nodes or unfortunately sometimes throughout the rest of someone's body. And you're right. We find patients diagnosed with this disease far too often after it has already spread to other places, and that's just too late. And you are right in that many of these rather vague symptoms can contribute to a patient presenting or seeking our care too late. For example, many folks will lose 30 pounds over the space of 3 or 4 months, and they'll be excited because they've spent years trying to lose weight. And while they celebrate for a period of time, it can ultimately come to sort of be that there's something else going on and there's something wrong. Or again, we talked about this just a little bit a few minutes ago, the development of diabetes for somebody who really doesn't have other risk factors for diabetes. Someone who might be young, healthy, watches their diet, exercises all the time, and yet develops this new onset diabetes that's difficult to control out of seemingly nowhere. Those patients are at risk for pancreas cancer, and a conversation should be had with their physicians or providers.
Interesting. That's right. And what about you said jaundice is a sign or something, but what about those who have darker skin? How can they tell if their skin is yellowing?
It can be a real big challenge to actually determine that. There are some things, though, that we can help with, and one of the things is the eyes. So not only will the skin start to turn a little yellow or jaundiced, but the whites around the eyes can turn icteric, is what we call it, but it's when the eyes themselves start to turn yellow as well. The other things that tend to correlate with that are patients have stool that will be lighter in color than it used to or urine that's darker in color than they're used to. So
Okay.
some folks would describe that as kind of a tea-colored urine or a very dark colored urine, whereas normally our urine is, of course, nice and light yellow in color. So those are the other kind of symptoms that can accompany jaundice.
Oh, that's definitely good to know. And we talked about you know, late being diagnosed later in that stage. What is the average stage, if you will, without, pinpointing something specific if you don't know, but what is like the average stage that that symptoms will appear and people actually start seeking help? When do you
Yeah,
find that out?
it can be remarkably variable because small tumors, there are two things that can happen that can determine when we figure it out. The first is jaundice. If you happen to have a small tumor that blocks something important, we can find those patients and diagnose them relatively early. But small tumors in other parts of the pancreas that might not block something as important, we might find late, or they might spread to other places in their body too early. When you look across the spectrum, there are four stages. Stage four usually indicates that the tumor has spread from the pancreas to somewhere else in the body. And almost half of our patients present with a tumor that has already spread to somewhere else in the body.
And how does that spread change their prognosis, like the diagnosis and moving forward?
It can change that quite dramatically. Historically, we have really been challenged to truly cure patients with pancreas cancer after they have had disease spread. So finding pancreas cancer late really changes someone's prognosis or how their life might unfold over the next 6, 12, 24, or 36 months.
And how can patients differentiate the symptoms that might be associated with, pancreatic cancer and then other digestive issues? Or is that something that no matter what, we should go to the doctor?
It's my opinion, and I think it's fairly indicative of where we are in the landscape of public health. But I really feel as though major changes to someone's health that seem to come out of the blue should be a conversation with your physician. So, as you have patients who really drop a lot of weight, perhaps without trying, that should be a conversation with the physician. If your skin is changing over the course of weeks to months, or your eyes are changing, or your urine or your stool changes dramatically in color, that should be a conversation with your physician. If you wind up having diabetes and you otherwise have no risk factors, then the conversation should revolve around why would that person be at risk for diabetes? What might otherwise be going on that we could help with to try to make sure there's nothing else perhaps more sinister going on? So I am a big advocate for maintaining an open line of communication with your primary care physician and others who might be participating in your care.
And speaking of our primary care physicians or our other practitioners, is there a screening process that we can request or that is normal in our everyday routine checkups?
So there's not a lot of stuff currently that we're incorporating into a annual checkup, if you will, outside of patients who have unique risk factors for this cancer. So, for example, patients with a strong family history of cancer, usually that is defined as two first-degree relatives. That's going to be mom or dad, or siblings, or children, or a line of a grandparent plus the same parent, or plus a parent on that same side. But first-degree relatives, if there are two or more, then you're at risk for the development of familial pancreas cancer. Those patients should take under consideration a more advanced sort of monitoring program that can include things like MRIs and CT scans and endoscopies, which are procedures where you're put to sleep and they put an ultrasound probe down through the mouth into the stomach to look at the pancreas directly from the stomach's view. So there are things that we can do for patients who are at high risk. One of the most exciting things I think coming down the pipeline for patients and families who are at risk for pancreas cancer is the development of a blood-based screening tool. This is a blood test that not only screens for pancreas cancer, but there are tests that can screen for a myriad of cancers out there and can look for augmented or changed DNA that exist alongside pancreas cancer or come from the cells that are derived from pancreas cancer, as well as other markers in the blood that might indicate that there is a tumor in the pancreas.
And so once we have that, we get that process. And what if somebody does have a positive indicator on there? What are the next steps? Like, what does the diagnostic testing look like to confirm pancreatic cancer?
Yeah, so the diagnostic testing for pancreas cancer usually involves a CT scan or an MRI. This can vary a little bit from institution to institution. Here at Johns Hopkins, we tend to prefer CT scans when we're looking for a cancer, as opposed to looking for a pancreas cyst or something of that nature, in which we might prefer an MRI. But those are the two kind of baseline tests or studies that we will use as the first step. We then tend to diagnose pancreas cancer formally with a biopsy in almost all cases. Biopsies are done through that endoscopic approach that we had talked about just a minute or two ago, where you're put to sleep and a camera is placed down through the mouth directly next to the pancreas, and then a needle is inserted into the tumor to get cells from that tumor to look at under the microscope. That tends to be the actual way in which we diagnose a patient with pancreas cancer almost all the time.
Wow, that does not seem like it's very comfortable.
It can seem scary, understandably. A patient's usually asleep. So the
Oh,
worst of
okay.
it,
That's
the-
helpful.
yeah, the worst of it is usually that folks can have a sore throat afterwards.
That's we can deal with that other than even the scary needle sometimes. That seems like a lot. And
Yeah.
so, okay, we go and we're testing these cells and we find out that the biopsy is confirms it is cancer. What are the current treatment options that are available for those patients?
So if someone were to see me or my colleagues at Johns Hopkins, where we do, more of this surgery than anywhere else, we tend to describe 5 treatment options for patients, and we lead someone through those treatment options. The oldest treatment option for cancers in the world is surgery. We've been doing that for thousands of years in some cases. And surgery is an option for many patients who have pancreas cancer that's limited only to the pancreas or surrounding lymph nodes. The second oldest treatment for cancers of all types is radiation therapy. And in some cases, we will use radiation therapy for pancreas cancer, but not all. So it's important if someone were to consider radiation therapy as a primary mode of treatment for pancreas cancer, that they see somebody at a major center like Hopkins or elsewhere that might do this a lot. It is relatively atypical to use radiation therapy as a primary treatment role for pancreas cancer. The next sort of treatment option that came along for patients with cancer is chemotherapy. And chemotherapies are used for pancreas cancer. In fact, almost all patients should receive chemotherapy if they can otherwise tolerate it. The chemotherapy for pancreas cancer is delivered usually through a vein, and it can be given anywhere from a few hours to a few days using a special pump that patients can take home. Chemotherapy is usually delivered in a manner in which you have chemotherapy and then you have a week or two off and then
Mhm.
another dose. The standard treatment course for pancreas cancer for chemotherapy tends to total about 6 months. Again, there are variations from patient to patient, but nevertheless, that's the general total. The next thing we've started to use for pancreas cancer are things like immunotherapies.
Mhm.
These are drugs or medications which unleash your own immune system, your own body, to fight that cancer. While immunotherapies have worked tremendously well for many cancer types, like melanoma and some others, the patients who are eligible for immunotherapy for pancreas cancer, that number is fairly small. This is an area, again, where Johns Hopkins has a lot of clinical trials, immunotherapies, and vaccines to try to help expand the use of immunotherapy in pancreas cancer. But it's not something that I would say is normal just yet for every patient.
And is that because of how advanced pancreatic cancer usually presents when most patients come in?
It's actually because immunotherapies work by noticing that a cancer is different from your normal cells.
Okay.
So your cells have to really notice that that cancer shouldn't be there.
Mhm.
It turns out that pancreas cancer, for a variety of reasons, really wears, the analogy I'll sometimes use is pancreas cancer wears a great coat.
Mm.
That coat looks like you. So it can be tough for your own immune system to really recognize a cancer, a pancreas cancer in particular, as foreign, as different, as something that shouldn't be there.
That is so interesting.
And
Very
that
interesting.
and that's why the research is there, trying to really get to a point where, the cancer has to shed its coat and your tumor or your body can recognize that tumor as foreign, as not you. The fifth option is something that we call, or the fifth option for treatment for patients is something called targeted therapies.
Mhm.
These are types of drugs which leverage or utilize unique mutations in a specific patient's tumor and then can treat a tumor based on that mutation. Those types of therapies often involve genetic sequencing and then referrals to a center that see enough patients where they can place these patients with unique genetic mutations into a proper treatment paradigm for them. There are places that do that very well and very often, but overall, the number of patients who are truly eligible for those types of therapies as a standard are
Mhm.
low. Lastly, if you were to come to one of our clinics at Hopkins, although we talk about those five treatment options, surgery, radiation, chemotherapy, immunotherapy, and targeted drugs, there's really a sixth. And the sixth is that some patients don't want to do anything. And at a place like Hopkins, as we start to treat our patients, we want to make sure that we reflect the patient's goals in their treatment program. So it's important that we place the autonomy or the capacity to decide with the patient. So in our multidisciplinary clinics, we walk folks through those six options and help them to decide or pair which treatment strategies may align most with their personal goals for health.
Right. That makes the most sense. When I go out into the community, I always emphasize to the community to make sure that they're collaborators in their medical experience, that they're not subjects to the doctors, that they should be collaborating. So it's so good to hear that you offer options that somebody can decide. And
Yeah.
so what factors influence like that their life, their prognosis? What are some of those factors after they're diagnosed and they choose one of those six options? What factors kind of determine their longevity afterwards?
The major factor is disease stage, and in
Mhm.
particular, whether their tumor is limited or confined to the pancreas or surrounding tissues versus a tumor that has already spread. When we see a patient whose tumor is confined to the pancreas, has not yet spread, those patients we are able to place in a treatment program if they'd like, with a target towards cure. Cure in pancreas cancer does require surgical resection. It requires going through a big operation with me or one of my colleagues. But that is the major driver of prognosis in pancreas cancer. The secondary things that then can help taper or tailor that prognosis is whether or not patients receive the appropriate care. Are they in a center that knows what they're doing, that can diagnose and then manage chemotherapies and other associated systemic therapies and perform surgeries that are advanced in a way that keeps a patient safe?
Yes, all of that, because
Yeah.
it goes hand in hand. You're exactly right.
All
And
pancreas cancer is one of those diseases, it's one of those diagnoses where patients really should try to see a physician at an experienced center.
yeah,
Over and over again in our field, that's been shown to really change prognosis and survival.
and are there any new promising treatments that might kind of change the type of treatment options we have, or maybe extend prognosis? Are there any new horizons?
Yeah, so I think there's a number of things, and we've hit upon a couple of those already. The first piece, if we were to go back in our journey of a patient, the first is diagnosis. And really, one of the major problems is that patients are not diagnosed early enough. If we diagnose patients at stage one, we can cure those patients. In stage four, the options that we have are those that tend to focus on extending life, but not necessarily cure. So if we can get more patients diagnosed earlier and earlier, we have more treatment options. And this gets back to those types of blood screening tests that we were talking about that are currently being trialed and many are being rolled out. It's important as we diagnose patients earlier that then patients find those high volume physicians to help take care of them. If we were then to move from that first treatment strategy to how we can potentially diagnose better, there's actually AI. And I know AI is really popular to
It
read
is.
about on the news and maybe for your kids to use in their homework nowadays. But AI can actually remarkably help our radiology colleagues find these tumors sooner too. Some of the most heartbreaking stories that we see include a patient who maybe was in a car accident last year and got a CT scan and was sent home and everything was fine. And then we see them a year later with a pancreas cancer. And if we look back a year ago, we find, oh, darn it, I can see that pancreas cancer on their CT from the car accident. And AI can help us to actually do those sorts of things.
Yeah,
To
that extra set of eyes. Because if you weren't looking for, if you weren't taking that MRI to look for a tumor, you were looking for something else,
yeah,
damage from the car accident. It's nice to have that extra set of eyes that's scanning
that's right.
faster than we can.
That's right. And these small tumors and organs which rest way back inside the abdomen can be very challenging to find. There's no doubt about that. So we have screening tests, we've got AI, and then in the surgical field, we have the capacity to operate on more and more patients more and more safely. Historically, there was a group of patients who had borderline resectable disease or locally advanced disease. These are patients who have tumors that maybe are wrapping around major arteries or veins in the body. And historically, surgeons would look at those tumors and say, I can't get that out without taking your life. And it would limit the options for patients. Nowadays, over the last 5 to 10 years, my colleagues and I at Hopkins and some others around the country are able to take patients with that stage of disease to the operating room and keep them on that curative path. So, surgically, our techniques and our capacity to resect tumors and keep patients safe while doing it have advanced dramatically in the past 5 to 10 years. On the medication side, we already talked about two of those too. While we have the traditional chemotherapies that we use, things like immunotherapies and targeted therapies are rolling out at almost an unbelievable clip. There really are a number of treatments that are coming down the pipeline that are really helping a dramatic number of patients. And it's reassuring. I mean, it's really, really great to see.
It is, and it is especially when we talk about how challenging it is to catch it so early and how tragic it can be when we don't catch it early. And so it's great to hear that there are potentials to help us save more lives.
Yeah.
And when it comes to screening, the potential screening test that you mentioned, through blood work, is that something that would be suggested for everybody or just people that are still high risk?
There's a little bit of a debate in the field, and many of our research programs right now are focused on that exact question
Interesting.
because we want to know really when we start to find these cancers in a way in which we can help patients. In other words, we don't want to find patients in whom the test might be wrong, and we start to look and explore and maybe hurt them with other procedures that are designed to try to help. These are called false positives, if you will. So part of the testing that revolves around these types of next generation screening tests is how we can find the balance between identifying these tumors early while not hurting patients in doing so. So that's the first piece. Part of this is certainly going to be age. At what age should we start to screen patients? Just like colonoscopies, there's an age at which you should start to receive a colonoscopy for colon cancer. There's going to be an age in which routine screening for things like pancreas, lung, and other cancer types should be recommended. Part of this is also going to be due to risk factors. So, for example, patients with a very, very strong family risk of pancreas cancer should be screened much, much earlier than those patients who are in families with no family risk factors for cancer. So, part of the research going on now is really to try to find that balance.
And so before I go into like some key takeaways that you might want to provide with the community, I do have some questions in the chat that I'd like to share with you.
Oh, yeah, please.
So one, so it says pancreatic cancer is known for being very difficult to detect early. What are recent identified signs or risk factors that members of general community should be aware of? Oh, I think we did talk about that one.
Talked a little bit about that one, but certainly keeping our eyes open for those next generation blood tests. And then the other things like new onset diabetes, unexplained weight loss, vague abdominal pain or discomfort that doesn't go away, and having that open line of communication with your physicians.
And so I think that that's great, and it kind of flows right into the next question. How are members enrolled into the National Familial Pancreatic Tumor Registry? And what are the potential obstacles to having greater representation within the registry?
Yeah, so I'll answer those questions almost backwards, if you will.
Okay.
So one of the obstacles to building out that type of registry is funding. And this is why it's incredibly important and so valuable when we see our community members engage with both funding bodies at the national level, maybe through the NIH and the federal government, and also advocacy bodies that sort of advocate for patients with pancreas cancer. So a lot of that type of work is really limited in part by funding. That being said, the common way that most patients will be enrolled in that type of program, whether it's the NFPTR or the CAPS program, which is the program that really focuses on certain high-risk families and has run it at Hopkins for a while, the program or getting into those programs involves usually an initial consultation with a physician in a cyst clinic or a pancreatic cancer high-risk clinic. Here, that's a phone call into our institution and a meeting with either a gastroenterologist or a surgeon who help to communicate and build the relationship between that patient and our familial database programs.
And so when speaking of programs, and I know we've talked about clinical trials, a question in the chat said, what should patients and families know about joining clinical trials at Johns Hopkins?
I love that question. I I've been at Hopkins long enough to recognize that some folks feel or know like or not know, I'm sorry. Some folks are under the impression that you have to participate in a clinical trial to receive care at a place like Johns Hopkins. This is not true. Although we have clinical trials available to our patients, it is not required that patients receive or participate in a clinical trial to receive care with us at Hopkins. So that's number one. Number two, we do have some rules for clinical trials that we invite our patients to participate in. And in general, those clinical trials have to, number one, be promising enough that we feel strongly that our patients and or the research would benefit from their participation. And number two, importantly, a clinical trial cannot take an option that we otherwise know is effective off the table for our patients. For example, we do not participate in clinical trials in which surgery is replaced by something else that's not potentially curative. So those are the two general guidelines. Everybody who comes through Johns Hopkins and our pancreas multidisciplinary clinics are actually screened for involvement in clinical trials. That being said, again, though patients are initially screened or looked at and their cases are available, or sorry, they might be available to participate in a clinical trial, that is not required for a patient to receive care with us.
That's very good to know, and because I can see how that could be misconceived in the community that, it's an option, but it's just that, an option. It's
That's
not
right.
required.
That's right.
Another question just talks about research that's happening currently at Hopkins surrounding the treatment of pancreatic cancer.
Yeah. So we have a program that's been long standing and dedicated to the investigation of immunotherapeutics in pancreas cancer. And that's one of the main focuses of our cancer center. How can we utilize vaccines in patients who might be at high risk to prevent the development of cancer? How can we utilize certain medications to uncoat the cancer or release the patient's own immune system to recognize and fight a cancer? We also have a large laboratory investigation and a large investment in early diagnosis with both AI through Elliot Fishman and our Department of Radiology, as well as blood-based screening tools with Bert Vogelstein and a team of researchers who are focused on that. And then lastly, we have a wide variety of researchers who are focused on things like familial pancreatic cancer, how to best find those early. My research focuses on pancreatic tumor modeling and the development of pancreas tumors outside the body to focus on what patients might be uniquely susceptible to, what drugs might uniquely help one patient versus another. And I'm assisted by my colleague Jackie Zimmerman, who's one of the medical oncologists with us here at Johns Hopkins. So there's a lot of research going on in pancreas cancer here at Hopkins, and it's an exciting time. There's no one else, nowhere else I would rather be for sure as a someone who does research as well as operates.
Oh, we're good. Glad to hear. That means we're not going to lose you anytime soon. So great, great, great. And so I also had a question, and then it kind of ties into this last question in the chat. But we're going to go back to like diabetes and pancreatic cancer.
Yeah.
When we talk about the resection of the pancreas, what are some of the consequences that might come, like the lifestyle changes that happen after it? Is diabetes, because the question here is diabetes a consequence of pancreatic cancer? And maybe not the cancer, but could diabetes result from that resection?
Yeah, so those are two great questions, and we'll answer them separately. So the relationship between diabetes and the tumor in general, and then the relationship between surgery and diabetes.
Okay.
The first is that we do see an association in some patients between the development of diabetes or new onset diabetes and pancreas cancer. It is likely that a tumor can grow, can cause inflammation, and can change the function of the pancreas. And that functional change can result in a patient developing diabetes. So we certainly do see diabetes newly in patients who are diagnosed with pancreas cancer every day. So there is certainly a relationship there. The second question that you asked, the relationship between surgery and diabetes is also true. So if I operate and I remove portion of someone's pancreas to clear their body of cancer, they will be at an increased risk of diabetes long term. In fact, if I called every patient that I operated on 5 years ago and said, "Do you have diabetes?" If that patient had a Whipple operation, which is a complex operation that removes the pancreas head, about 25% of them would tell me, "Yeah, I've got diabetes now, 5 years later." If I remove their pancreatic tail or the other half of their pancreas, about 30% of patients will tell me that they've got diabetes now. Most patients who did not have diabetes beforehand will be on oral medications to manage that diabetes afterwards. But nevertheless, it is something that can be different in someone's life after a pancreas surgery versus beforehand.
And so is the diabetes a direct result of the surgery, or does lifestyle play a part in it? Like, is there a way that I can avoid
Yeah.
the diabetes?
Yeah, it's a great question. It's certainly as physicians like to, say it's multifactorial. And I feel a bit like a lawyer when I say that, but it is true. So for example, if someone had a Whipple and I call them on the phone, 25% of them are going to tell me that they have diabetes. But
Mhm.
if I were to call their twin on the phone who had lived those 5 years and maybe was a little bit obese or maybe didn't make the smartest choices with food, diet, and exercise and ask them, "Hey, do you have diabetes in the past 5 years?" About 10 to 15% of them are going to tell me, "Yeah, I've developed diabetes over the last 5 years too." So we think while the operation is one of the factors that can contribute to diabetes or the development of diabetes, it's not the only one. And in fact, the majority of patients who have a pancreatic resection will not develop diabetes over that time frame.
And what about digestive issues? Because we talked about how it aids in digestion.
Yeah.
So would they have to have any digestive issues potentially?
It depends again on which operation the patient might need. For
Mhm.
someone with a distal pancreatectomy, most folks after that operation don't notice any change in their digestion. A Whipple operation, though, is a complete rerouting, if you will, of the first portion of your bowel. In fact, we've got a wonderful Hopkins YouTube-based video on it. If you go to YouTube and search Johns Hopkins Whipple, there's actually a video that leads someone through a cartoon version of the Whipple operation.
I will share the link with everybody in the follow-up video with the recording.
Fantastic. So it's a great video, but it does show how the bowels need to be rerouted. In the short term, as someone recovers from an operation, there certainly is a change to how someone might eat and drink. However, within about 2 months of the operation, the vast majority of patients return to a normal diet and can eat and drink whatever they like. There is one caveat, and that is that sometimes patients will need an extra medication to help digest your food. In other words, to help replace the enzyme the pancreas makes that helps you to digest foods. If you recall back when we started, we talked about the two functions of the pancreas, controlling hormones or producing hormones like insulin, so diabetes as a result, and then controlling the capacity to digest your food with the creation of an enzyme. And sometimes you might need enzymes after surgery for a short period of time as you recover.
This is great information. And if you can't tell that these most of these questions at the end are mine, I'm like, well, I want to know more. I have one more question in the chat though. It popped up. It says, what about having cysts? Is that a risk factor or an early sign of pancreatic cancer?
Fantastic question. Some cysts can be a warning sign or can, left to their own devices, go on to develop into a pancreas cancer. So, yes, unlike cysts in most parts of the body that are completely nothing to worry about, cyst under the skin, we're not going to worry about that. Cyst in the liver, by and large, not going to worry about that. A cyst in the pancreas, we have to try to figure out what type of cyst you have. There are some cysts that can develop from pancreatitis, for example, or other things that are completely harmless, that can stay there lifelong. They will not cause a problem, will not cause an issue. But there are other cysts, cysts that we call mucinous cysts or intraductal papillary mucinous neoplasms, IPMNs, that left to their own devices in some patients over some time can develop into a pancreas cancer. So again, one of the things that we offer here at Johns Hopkins from our surgery department as well as our gastroenterology department is a cyst-specific clinic. A
Now,
clinic that finds and sees patients with pancreas cysts, helps them to understand their risk, whether or not the cyst is truly risky. If it is something that can cause a cancer over time, help them to assess what their personalized risk might be. Are they high risk? Are they medium risk? Are they low risk? And then help them to make decisions about their own care. There are some patients in whom the familial disease will be noticed or will be tracked through the surveilling or watching of a pancreas cyst. So that's a great question.
how would I even know I had a pancreatic cyst?
Most are found incidentally, which means,
Mm.
just by luck. You had that car accident and someone said, "Hey, you've got a cyst on your pancreas." And someone along the way was smart enough to tell you, those cysts aren't like other cysts. You might want to have that looked at. So that is a great question that otherwise would be remiss for us not to mention tonight.
And he said, wow, I didn't know that there were clinics specialized only for cyst evaluation. Thank you very much.
Yeah, there are. We've been doing it a long, long time, and we have the busiest cyst clinic actually in the nation too. So we're happy to see folks there as well. We've published on that. There's great data out there in the literature, and we use those data actually as the foundation of most of our meetings as we see patients with pancreas cysts.
I have another question about the future of pancreatic cancer identification screening, if you will. It says, do you see a future where liquid biopsy markers identified at Hopkins or elsewhere could reliably detect minimal residual disease after surgery? How is MRD testing emerging at Hopkins?
Yeah, so this is a great question. The answer to that is that, uh, I mean, not to be too cliche, but the future is kind of here on that one. So yes, we historically would use CT scans and blood work to determine or evaluate for disease recurrence or minimal residual disease after surgery. In sort of the modern era, there are now services which will screen for residual DNA. So if we know, for example, that a tumor had a particular mutation, we can screen the blood for the presence or absence of that mutation. There are a couple of research-oriented questions, I guess is the best way to frame that, that remain unanswered. Specifically, number one, we don't necessarily know that those tests are accurate all the time for all patients. Number two, we don't know if our discovery of a DNA mutation should prompt earlier treatment with things like chemotherapies or immunotherapies or otherwise. Although it would seem to follow that that would be a smart idea, we don't have phenomenal data to suggest that that's truly the right way to go. And remember, our chemotherapies and our drugs can hurt people too. So those are kind of the questions that are currently being asked around things like blood-based sort of biomarkers of disease recurrence.
Thank you for that. Our chat is on fire. I have another question for you.
Oh, I'm not monitoring it. I'm glad you are.
It says we talk about first degree relative, but what about second degree relatives? I wonder because my grandmother sadly died of pancreatic cancer. Should I do something special or am I at average risk?
Gosh, number one, I'm sorry to hear about your grandmother. It is a terrible disease and historically was just terrible. Um, so we don't know the answer for every patient, and there are some things that can color our decision making as we try to assess risk for folks. Most of the time, when we see somebody with one second degree relative with pancreas cancer, we sort of consider those folks to be of average risk. But there are patients in whom that might change, particularly patients like who might have a BRCA mutation or a mutation in the gene that might be more commonly recognized as the breast cancer gene. Or there are genes that actually can drive colon cancers and things like that. And the association between pancreas cancer and certain types of colon cancer in families and breast cancer or ovarian cancer, these types of things can help us to assess risk as well. Most of the time, a second degree relative, a single second degree relative, would not be enough for us to say that the additional screening, as we know it now, would be truly beneficial. That patient we think is likely to be more, or is more likely to be of average risk than of elevated risk.
Uh, great, great way of breaking that down because it is hard to tell, especially with a lot of cancers. We sometimes we really don't know if there's no like we've seen the genetic defects. We really don't know if what your risk looks like. I think that's the scary part, and especially when it comes, there's no screening and is it necessary for everybody to get screened? Like you have all these questions, is my risk really high? But I get it. I get
Yeah.
that it's
Yeah.
a weird position to be in.
It can be, I mean, this disease can be very scary. There are often times where we have limited information about someone's, whole family history or health history and otherwise, and it's completely understandable that folks would have real deep questions about things like that.
And so as we prepare to close for this evening, because this has been a wonderful talk, um, on a community level,
Yeah.
what could we do to improve awareness about pancreatic cancer and early detection for people who might be at risk?
Yeah. I think that's great. So if I were to say, okay, what are my takeaways for this? Number one, the first takeaway would be advocacy, making sure that our communities recognize pancreas cancer as the third leading cause of cancer-related death in the United States. Despite only having about 50 to 60,000 diagnosed each year, it is a leading cause. And advocacy for early diagnosis, for community monitoring, and for research really goes a long way. The second thing that I would say as the takeaway would be understanding someone's risk, recognizing those early warning signs, whether it be jaundice in our families and our friends and our loved ones, whether it's unexplained weight loss, whether it's a family or friend or loved one who has a strong family history but doesn't recognize their risk. Making sure that we stand together and really advocate for each other for these types of diseases, which might otherwise be forgotten between the headlines, if you will. And then lastly, thinking about our patients who are diagnosed with this disease, trying to get them to a place that deals with this tumor and this type of cancer all the time. This is the type of cancer that, when seen and evaluated at a high volume center, patient outcomes are better. When patients have options for clinical trials and participate in clinical trials, their prognoses tend to be better. When patients have community support and can navigate the things that go along with that diagnosis of pancreas cancer, their outcomes can be better. Those, I think, would be my takeaways.
That's an amazing way for us to remember how we can take the awareness of pancreatic cancer with us, making sure that if we know somebody, get them to a well-rounded center like Johns Hopkins. And knowing the signs and symptoms and not being afraid to talk to your doctor. Don't take the year and have the symptoms, talk to your doctor. It's better safe than sorry.
That's
Is
right.
how I'm seeing this, because even if it can mimic something else, it's worth bringing up.
That's right. That's right. It can be intimidating sometimes to make that phone call or to write that email or that my chart message or whatever it is, but
Yeah.
it's worth it. It's
Take
worth
the
it.
time. Yeah. So I appreciate you so much, Dr. Burkhart. It has been a very enlightening conversation. And I hope that those listening, this was recorded, it's going to be put on our YouTube page. So we look forward to more people being able to take away from this message the way that I did tonight. I'm full. I am grateful.
Well, thank you. I appreciate the opportunity to join you tonight and to talk a little bit about a disease that we're passionate about curing. So thank you.
Thank you. Everyone have a good night. We will see you next month.
Take care.